All right, let's talk about carbon dioxide transport. So, carbon dioxide transport. Carbon dioxide is transported from tissues to lungs. Simple. In three forms. The first form it is transported in is bicarb, which is about 70%. So most of the questions come right here. Um, Most common transport of carbon dioxide is what is bicarb. How does it do it? Let's read that. So there is a bicarb chloride transporter on RBC membrane that allows the bicarb to diffuse out of the plasma and the chloride to diffuse into the RBC, which is known as a chloride shift, via facilitated diffusion countertransport. So that is depicted right here. So if you look here, what are you seeing? The bicarb is going out, and the chloride is coming in to the RBC, and this thing is known as chloride shift, and that is done by through this channel, which is bicarb chloride transport channel uh, on the RBC surface. The second most common type of transport for carbon dioxide is carb carba carbaminohemoglobin, or HbCO2, which is about 25%. Um, so CO2 would bind. Give me 1 second here. Okay, yes, better. Okay, yeah. CO2 would bound to the hemoglobin at the end terminus of the globin, not the heme, and CO2 favors deoxygenated form. O2 is unloaded. Let's look at this now. So this is right here. So they're saying CO2 binds to the hemoglobin Hb, and it forms HbC CO2, which is your carb amino hemoglobin. And this is about 25%. So this is about 70, 25. So now we're left with the remaining, and we will see how that goes. That is just dissolved within plasma. It's that 9%. So in lungs, oxygenation of hemoglobin promotes dissociation of hydrogen ions from hemoglobin. This shifts the equilibrium toward the CO2 formation. Therefore, CO2 is released from the RBC, which is known as a Haldane effect. So majority of the blood, CO2 is carried as bicarb in the plasma. So if you look here in the tissues, we have CO2 that goes through the capillary wall from plasma into RBC, binds water through an enzyme known as carbonic anhydrase, forms H2CO3, that is going to form hydrogen plus bicarb. Bicarb goes out. That hydrogen ion then binds to the Hb negative. What do we mean by Hb negative? Well, Hb minus basically means it's a deoxygenated hemoglobin. So it binds to the deoxygenated hemoglobin, finds HHB. Okay, and we talk about very two important things. Chloride shift important. Haldane effect is important. So the way I think about Haldane is, so Haldane, right? Haldane effect is for unloading. So Haldane effect is to unloading of CO2 in the lungs. Unloading of CO2 in lungs. So basically, in other words, CO2 is released from RBC in the lungs, right? That's Haldane effect. So there is another effect known as Bohr effect. Let me just write it here. Bohr effect. What is Bohr effect? Well, Bohr effect, it's the unloading of O2. Unloading of O2 in the peripheral tissues. And how can we memorize this now? So BO is for O2 in the Bohr effect. So remember, all these two effects, they are for unloading. Both are doing unloading job. One is doing CO2, one is doing O2. Now just we gotta know which one is doing what, right? So here, because it's one O, we can say it's O2. So Bohr O2 effect. And the other one, if this is O2, the other is going to be halidine, which is CO2. Okay, what else we might have here? So yeah, that's I guess yeah, that's pretty much it for this one. Let's move on to the next topic, which is hypoxia and hypoxemia. So what is hypoxia? Basically, hypoxia is decreased O2 delivery to tissues, right? And what is hypoxemia? Hypoxemia decrease O2 concentration within the blood. So decrease basically PaO2. So hypoxia is, on the other hand, is just decreased O2 delivery to tissues. So it is due to decrease in cardiac output, uh, or either hypoxemia, which again is insufficient oxygenation of the blood, with decrease in PaO2. Just remember decrease in PaO2. Hypoxemia, decrease in PaO2. Ischemia, anemia, CO, cyanide poisoning. All of these are the factors that would cause decreased O2 delivery to tissues. Now, looking at this here, if there is a decrease, how do you have hypoxia here? The first scenario we have here is decreased inspired oxygen tension, PiO2. I means inspired, so partial pressure of oxygen, inspiring oxygen. So PiO2 is decreased. That means what is PiO2? PiO2 equals FiO2. FiO2 times Pb, which is your atmospheric pressure and your water pressure, most commonly due to decrease in BP in high altitude. So remember, in high altitudes, your atmospheric pressure, which is your Pb, would decrease. And you say, what is high altitude? Like, how can we say, what level is high altitude? So greater than 2,500 meters. So when you're above sea level, greater than 2,500 meters, that is your high altitude. So high altitude is one of the causes that would decrease the PiO2. Now, hypoventilation due to increase in PaCO2, that would lead to also hypoxia. So let's read how. So PaO2, which is your partial pressure in the alveoli. Big A is for alveoli, small a is for artery. So here big A, so alveolar O2 equals PiO2 minus the arterial CO2 divided by RQ. Example, CNS depression from opioid overdose, obesity, hypoventilation syndrome, neuromuscular weakness. So all they're saying is these three causes, CNS depression, obesity, OHS, obesity, hypoventilation syndrome, and neuromuscular weakness would all cause hypoventilation. So when you hypoventilate, you're going to increase the level of CO2. That's all they're saying. The third one is about your diffusion limitation. And we give fibrosis. For example, this is the alveoli, right? We can see that this is alveoli. And here is the diffusion limitation, because now here is going to be the blood supply. And this diffusion limitation is not letting the oxygen particles go into the RBCs, into these capillaries, because of this fibrosis called diffusion limitation. And one more thing that is also written here, that if you are decreasing the PiO2 or hypoventilation, that is your normal AA gradient, okay, and this will just cause normal AA gradient, while all these factors would lead to increase in AA gradient. And this will be on the this is also running live on YouTube, so if screen is not clear here, you can always go live on YouTube and look at that over there. Okay, so let's get back here. So let's look at the factors that are going to increase the AA gradient. So we talked about diffusion limitation. Now the second, fourth thing that we are looking at, we're going to look at VQ mismatch. So what is VQ? Ventilation perfusion mismatch. So that if you have a normal perfusion in areas of decreased ventilation, for example, COPD, pulmonary edema, pulmonary embolism, you're going to have a VQ mismatch. So these are all the factors which would cause VQ mismatch. Um, okay, and the fifth thing is about right to left shunt, the extreme of VQ mismatch. So normal perfusion in the areas of no ventilation can be anatomical, for example, intracardiac shunt, or physiological, example, perfusion of non-ventilated alveoli in ARDS. And you can see that over there, that there is no, you can see that there is no air here. And that's a shunt, that the blood is coming, but there is no air, there is shunting, right? And here was just the fibrosis right here. And here we just have the air isn't coming much, that would go down. So this is all about hypoxia. And let's talk about hypoxemia now. Hypoxemia, on the other hand, is just insufficient oxygenation of blood, decrease in P small a O2. Okay, that's all for that topic. Let's talk about hemoglobin. Hemoglobin, it has normal adult hemoglobin is composed of 4 polypeptide subunits. So we can see that we have 4 polypeptide subunits, 2 alpha and 2 beta, 4 total, that each bind one oxygen molecule. HB is allosteric protein that exhibit positive cooperativity when binding to O2, such that the oxygenated hemoglobin has a high affinity for O2, 300x, while the deoxygenated hemoglobin has a low affinity for O2, which promotes the release / unloading of O2. So the important term here is positive cooperativity, which is basically saying if one oxygen binds, the rest is easy to bind. By how much? 300x. And if you're in deoxygenated state, there is a low affinity. If you're in deoxygenated, there is a low affinity for O2 to bind. That is positive cooperativity. Okay, on the other hand, the protein component of hemoglobin acts as a buffer for hydrogen ions. Myoglobin, composed of a single polypeptide. Here we have 4 polypeptide subunits, and that myoglobin is just a single polypeptide chain associated with one heme moiety. Higher affinity for oxygen than hemoglobin. So they're saying myoglobin has one, but it also has a higher affinity for oxygen than even hemoglobin. So just take a type of factoid. But the next one, here we have oxygen content of blood. So O2 content equals the O2 bound to hemoglobin plus the O2 solubilized in plasma, that equals 1.34 times hemoglobin times saturation of O2 plus 0.003 times PaO2. This is just a formula. You just gotta know this. So what is SaO2? SaO2 is a percent saturation of arterial blood with O2. What is 0.0? Where do we get this number? It's a solubility constant of O2. PaO2 is a partial pressure of O2 in the arterial blood. So this is important now. Normal 1 gram of hemoglobin can bind 1.3 ml of oxygen. So 1 gram hemoglobin binds 1.3 ml. So normal hemoglobin amount in blood is about 15. So just think about it. 15 times you're getting 1.34. So this is how much you are oxygenated at a normal hemoglobin level. So when you're anemia, when you have anemia, you're not enough oxygenated, causing hypoxemia, hypoxia, all that. So looking at the second point here is O2 binding carrying capacity. About is 20 ml of blood. Okay, that's about 20 ml. With decreased hemoglobin, there is decreased O2 content of arterial blood, but no change in O2 saturation and PaO2. So with anemia, there is decreased content of arterial blood, but there is not going to be any change in O2 saturation or PaO2. O2 delivery to tissues equals cardiac output multiplied by O2 content of blood, right? And this is little high yield table what do we have here? So, CO poisoning, anemia, polycythemia, methemoglobin, cyanide toxicity. Uh, HB concentration in CO poisoning is normal. In anemia, it's going to be decreased. In polycythemia, it's going to be increased, while methemoglobin normal and cyanide toxicity normal. Saturation of O2 is decreased in CO, while normal in anemia and polycythemia, and methemoglobin that is going to be decreased. And why is decreased here? Okay, wait, let's talk about CO first. So CO would compete, so carbon monoxide would compete with oxygen, that's why the saturation is decreased. Here, why is it decreased? Because Fe3 state, which is the ferric state, has a poor binding for O2. So if you recall, I guess pathoma, it's Fe2 binds O2, so all the 2's bind together. So this is Fe3, so there's a poor binding, and cyanide just has a normal. So if you just take out cyanide, I guess if you look at cyanide, everything is normal. So cyanide is just out of the box. Everything is normal. Every single parameter is normal. So we're left with the other ones. Well, the PaO2, the partial pressure of oxygen, is normal in every single disease, so we can take out this box as well. Total O2 content, well, it is decreased in CO and anemia, but increased in polycythemia and also decreased in methemoglobin. So you can say it is basically decreased other than polycythemia, right? So this is all about the oxygen content of blood. Now we're going to look at oxygen hemoglobin dissociation curve. So it shifts in oxygen hemoglobin dissociation curve. ODC reflects local tissue oxygen needs, can be helpful to meet the metabolic needs, or harmful in toxicity pathophysiological situations. Right shift in ODC reflects decrease in hemoglobin affinity for O2, that will lead to increase in O2 unloading at tissues. Physiologically occurring with increased O2 needs, example, exercise. So what are the physiological increased O2 needs? One is exercise, the other is decrease in pH, and that is the exercise decrease in pH. You have increase in temperature, fever, hypoxia, increase in 2,3 BPG at a cellular level caused by increase in bicarb, increase in CO2 created by tissue metabolic, which is a Bohr effect. We talk about Bohr effect. What was Bohr effect? Recall O2 unloading at the periphery. And how do I know O2? Because it's a Bohr. So this is the left shift, and if you look here, I'll make this simple. I'm just reading right now. So left shift in the ODC reflects increased affinity for O2, decrease O2 unloading at the tissues. Physiologically occurring at decreased O2 needs, example, temperature, decrease in temperature, pregnancy, fetal hemoglobin has higher O2 affinity than the adult hemoglobin, and increase in O2 due to decrease in affinity for 2,3 BPG. Left shift driving O2 across placenta to the fetus. Pathophysiologically occurring because of increase in CO, methemoglobin, genetic mutations, which would decrease the 2,3 BPG, and left is lower. So if you look at this graph, make thing normal. This is normal. The blue one is total normal, right? So if you have a left shift, the mnemonic here is going to be what? So left shift, left L for left, L for lower. Everything is lower. So if you look at all of these, it's just decrease. So decrease in temperature. It's going to be, everything is going to decrease in 2,3 BPG, except the pathological states. Except these, everything is decreased. So left is lower. And also, one more extra thing is about pregnancy. So pregnancy is also left. Okay. So, and what is right? Right is everything is higher. So if left is lower, the right is going to be, everything is going to be higher in right thing. So, and these are all these factor physiologically increase in O2 needs and all that. And O2 has a sigmoid, that's also high yield, sigmoid shape due to positive cooperativity, which is again tetrameric hemoglobin can bind for molecule higher affinity for each subsequent O2 molecule bound. Again, this is important, positive cooperativity, which basically means O2 binds more and more with 300x affinity. If one O2 molecule binds, the next one binds with an easier way to bind, which is about 300x more affinity for oxygen. Myoglobin is monomeric and thus does not show positive cooperativity. Curve lacks sigmoid appearance, if that's why the myoglobin is right here. So this one is a sigmoid appearance of the curve. Uh, and Other than just so one thing here we have is we have certain factors like what would cause the shifts, right shift and left shift, and these are some physiological and some pathological factors. That is just rote memorization. But other than that, you should know what is left and what is right. So left, easy mnemonic, left is lower, so everything that is lowered in physiology will be left shift. Anything that is higher in physiology will be a right shift. Other than the left shift, the extra thing that we have is pregnancy and some diseases. What are the diseases? CO poisoning, methemoglobin, and also some genetic mutation in the BPG. And that's all for oxygen hemoglobin dissociation curve. So response to high altitude, let's talk about this one. So we have a constant FiO2 in high altitude. There's a constant response to high altitude. So in the constant FiO2, but there is a decrease in the atmospheric pressure. And what is FiO2? FiO2, let me read this. It is the fraction of inspired O2. Fraction of inspired O2. So you have a fraction of inspired O2, there's this constant, because this is what you're inspiring in, but there is a decrease in atmospheric pressure, which is decrease in PB. This whole thing would lead to decrease in PiO2, which would cause, this is basically inspired O2, which would cause decrease in B small AO2 and increase in ventilation. This is important. That in high altitude, you're gonna have you will hyperventilate, and these are all the things because you would hyperventilate, but you will hyperventilate. That's one thing, right? And that will cause what? That will cause decrease in your carbon dioxide. And because remember, when you hyperventilate, which is like increasing the respiratory rate, hyperventilation, it will lead to CO2 going out. It throws out CO2. So that CO2 is acidic. It is an acid. So when the acid goes out, guess what you're left with? You are going to cause alkalosis. But where are we talking about? Are we talking about metabolic kidney or are we talking about respiratory? No, we're talking about respiratory here, right? So it's going to cause respiratory alkalosis. And that respiratory alkalosis now would cause altitude sickness. For example, headache, nausea, fatigue, lightheadedness, sleep disturbances. So if you recall, if you have went to some high altitude place, you will have acute altitude sickness, which is headache, nausea, fatigue, lightheadedness, all of that. So, but in chronically, high altitude would cause increase in ventilation. Same thing as acutely increase in ventilation. So what's going to happen chronically? That you will have increase in erythropoietin, EPO, and that would increase your hematocrit, hemoglobin, due to chronic hypoxia. Okay, and there would be increase in 2,3-BPG. So just remember these factors. In high altitude, you will have increase in EPO, increase in 2,3-BPG, which would do what? Which would bind to hemoglobin, make a right word shift. Again, go back to the mnemonic. Everything that increases makes the curve go to the right. Anything decreases or lowers, let's put it that way, L lower, L for left. right? So here, because we have increasing this BPG, we have a right shift of oxyhemoglobin dissociation curve, which will lead to increase in O2 release. Cellular changes, increases in mitochondria. Cellular changes also causes increase in mitochondria. Increase in renal excretion of bicarb. Because we develop respiratory alkalosis, how are we going to deal with that? So we will release that bicarb to compensate for respiratory alkalosis, can augment with acetazolamide. We can even give this drug acetazolamide that can help us potentiate respiratory alkalosis, the process of fixing that respiratory alkalosis. So chronic hypoxic pulmonary vasoconstriction can occur. Vasoconstriction can occur because it can lead to increase in pulmonary vascular resistance, which would cause pulmonary hypertension, right ventricular hypertrophy. Right? If you look into this one, how is it all that? So if you have this is your right atrium, right ventricle, and right ventricle is throwing into this pulmonary vessels. So now, because these vessels are not getting enough oxygen, they're going to go into vasoconstriction. When they go vasoconstriction, the right ventricle has to push way too hard to push that blood into these pulmonary vessels. So pulmonary artery. So what's going to happen is that right ventricle is going to get big. So here it is, right ventricular hypertrophy. Okay, now the next one is about response to exercise. Okay, response to exercise is increase in heart rate, an increase in stroke volume, which would cause increase in perfusion, which would lead to increase in pulmonary blood flow. So all of that just to get to this point, increase in pulmonary blood flow in exercise. That will lead to increase in VQ ratios, which is perfusion, ventilation perfusion ratio from base to apex becoming more uniform. And if you recall, what was the VQ in the base and the apex? So in the apex you had a 3 VQ, and in the base you had 0.6. So now they're saying it's going to become more uniform because V is also increasing and Q is also increasing. So everything will become uniform here. Increase in cellular respiration, which will cause increase in CO2 production and decrease in pH at tissues, which would cause right shift of ODC. Again, increase in CO2. I mean, this is the byproduct of increase in CO2 because this is acid. When acid goes up, the pH goes down, and that is the right shift of ODC, which leads to tissue offloading of more O2, which would cause increase in O2 consumption, and RR increases, respiratory rate increases to meet the increased oxygen metabolic oxygen demand and remove excess carbon dioxide, which leads to pulmonary increase in pulmonary blood flow. So this is one of the things. Second thing is PaO2 and PCO2 are maintained by homeostatic mechanism. Decrease in PVO2 due to increase in O2 consumption, and increase in PVO CO2 due to increase in CO2 production. And what is PVO2, by the way? So partial pressure of venous O2 and CO2. So partial pressure of venous O2 would increase. There's a decrease in partial pressure of venous O2 due to increase in O2 consumption. So basically, another way, in the veins, right? Veins, you have, let's say this is a vein, you have O2. If you consume a lot of it, you will decrease the level of O2 in the veins. Simple. But if you if you produce a lot of CO2, would come into the vein. That would increase the PvCO2. Simple. Now the next part is methemoglobin high yield. Let's talk about it. So methemoglobin is basically iron in hemoglobin Hb. Iron in Hb is normally in reduced state, which is ferrous Fe2, which is the mnemonic is either just 2 of us or Fe2 binds O2. Oxidized form of hemoglobin, which is going to be ferric Fe3, it does not bind O2 readily as F2, but has an increased affinity for cyanide. So Fe3 binds cyanide, right? Leads to tissue hypoxia and from decreased O2 saturation and decreased O2 content. This Fe3 state is called methemoglobinemia. While typical concentrations are 1 to 2%, methemoglobinemia can occur at higher levels and may present with cyanosis. Cyanosis does not improve with O2 and with chocolate colored blood. Three things. High yield, three things. It is cyanosis, does not improve with O2, chocolate colored blood. And what is methemoglobin? Fe2 goes into formation of Fe3, and Fe3 doesn't bind O2. What are the risk factors? Why did this happen? It happened because of dapsone drug, local anesthetic, which is benzocaine, nitrates can do it from dietary intake or polluted water source, causes poisoning by oxidizing Fe2 to Fe3. Methemoglobinemia can be treated by methylene blue and vitamin C. So methylene blue and vitamin C, and they will put back the Fe3 into Fe2 state and decrease the anything that is affecting it. So yeah, methemoglobin is easy. Just remember these two things. Cyanosis does not improve with O2 and chocolate color blood. Okay, moving on with cyanide and versus carbon monoxide poisoning, high yield. So what do we have here? So we have both the cyanide and the carbon monoxide, Cn negative CO, both inhibit the aerobic metabolism via inhibition of complex 4 of ETC, which is cytochrome C oxidase, which causes hypoxia that does not fully correct with supplemental O2, which leads to increase in anabolic metabolism. What are they trying to say? They inhibit complex 4, both of them. By inhibiting this, they're inhibiting aerobic metabolism. So guess what? One more thing. When they inhibit the complex 4, what are they not making? They will not be able to make ATP. So when they're not making ATP, they're going to go into anaerobic metabolism because they're inhibiting the complex 4. And even it is not corrected fully with supplemental O2. So 3 conditions. So let me actually put it here. The methemoglobin, let's say meth. So O2 not gonna help O2. So something similar here, not corrected with supplemental O2. But we will see if you give a hyperbaric oxygen, that's gonna work in the carbon monoxide. But we will see that later. So here, let's talk about cyanide. Cyanide now. What is the exposure? How do you get cyanide poisoning? Synthetic product combustion, amygdalin, high yield, amygdalin ingestion, which is in apricot seeds, cyanide ingestion in suicide attempts, fire victims. What else do we have? Let me just fire victims, suicide attempts, amygdalin, high yield, yep. So yeah, these are all the things that we can get cyanide from, right? And what about carbon monoxide? We are gonna get this from motor exhaust, gas heaters, and fire victims. So fire victims are in both the place. So we just have to see the features to divide them. Well, the motor exhaust and gas heaters is the more common cause of carbon monoxide poisoning. Now, what are this presentation? The presentation is going to be headache, dyspnea, drowsiness, serious coma. Skin may appear flushed, which is cherry red. Venules in the retina appear bright red. Breath may have bitter almond odor. Here also you're gonna have headache, vomiting, confusion, visual disturbances, and coma. But what is the question? One of the question is, what is the first feature that would arise in carbon monoxide poisoning? That is headache. The very first feature or the initial feature of carbon monoxide is extreme headache, and that is right here. Other than that, you just have visual disturbances as another hallmark. Visual disturbances, which would differentiate from the cyanide. Visual disturbances. On the other hand, here you just have bitter almond odor, right? They both can have a cherry red skin, so that's not a specific feature. It's a common feature with bullous skin lesions. Multiple victims, that's also important. It could be multiple victims. Maybe involve family due to the family forensics. And then the labs are also high yield. Let's talk about that. Labs. In the labs, we have normal P small AO2, which is arterial O2, and it is normal there as well. So no big deal there. Both have the same level of PaO2. Now, elevated lactate, which causes anion gap metabolic acidosis. That's important, specific for cyanide. While other one would give you elevated carboxyhemoglobin on co-oximetry. So elevated carboxyhemoglobin. So carbon monoxide is associated with a high yield bilateral globus pallidus lesion on the MRI. You can see that the globus pallidus bilaterally is just out. There's a lesion on the globus pallidus, although can rarely be seen with cyanide toxicity. Okay, effect on the oxygen hemoglobin curve. So the curve is normal in cyanide, but it is a left shift in ODC in the CO poisoning that would cause increased affinity for O2. That is going to lead to decreased O2 unloading to tissues. So oxygen saturations may appear normal initially despite ample O2 supply. It cannot be used due to ineffective oxidative phosphorylation. On the other hand, this one binds competitively to hemoglobin with a 200 greater than 200x greater affinity than O2 to form carboxyhemoglobin, and there's going to be decrease in O2 saturation of hemoglobin. So they are saying oxygen saturation may appear normal initially, and over here it is just decreased all the time. That's another differentiating feature. In the treatment, we are going to treat this cyanide poisoning via first thing decontamination, for example, removing the clothing. Then you can give hydroxycobalamin, which binds the cyanide, binds that toxin cyanide, makes a cyanocobalamin and leads to renal excretion. Other thing you can give is nitrates. Nitrates would oxidize hemoglobin, and that's going to cause formation of that methemoglobin, again Fe3 state of hemoglobin, which would bind the cyanide, take it out, make a cyanomethemoglobin, and decrease the toxicity of cyanide. The fourth thing we can do is sodium thiosulfate, which will increase the cyanide conversion to thiocyanate and cause renal excretion. So if you look, we have a couple of renal excretions here with this and this guy doing renal excretions. And for the treatment of carbon monoxide, 100% O2 would work, and hyperbaric oxygen if it is a severe case. And this is the ODC. So if you look, this is normal hemoglobin, but with the poisoning, CO poisoning, it is just it is a left shift. And now you call how it is a left shift? Well, it's a left shift because you have, here is the left shift. So this is a left shift, and you can see how with the hemoglobin there's a decrease in the O2 bound to the hemoglobin with that 50% only. So yeah, so let's just quickly recall this because this is very high yield, and then move on with the next topic. So we talked about how cyanide and carbon monoxide poisoning would cause anaerobic metabolism. One thing, anaerobic metabolism, because there is no ATP. Cyanide, amygdalin, apricot seed, suicidal and fire victims. There's going to be headache, most importantly, bitter almond odor with increase in lactate. Why lactate? Again, because of anaerobic metabolism, there's an increase in lactate, which would cause anion gap metabolic acidosis. The curve, ODC curve is just normal. Oxygen hemoglobin curve is normal. Oxygen saturation is going to be normal only initially. So the only lab problem we are getting is just elevated lactate with anion gap metabolic acidosis and bitter almond odor. Other than that, treatment is all here. On the other hand, carbon monoxide is motor exhaust gas heaters, headache, most common feature, most not common, but most the first symptom to come along is headache. Visual disturbances also there, and multiple victims could be there. Elevated carboxyhemoglobin is going to be there. Bilateral globus pallidus injury could be there. Left shift to the ODC, decrease in O2 saturation will be seen. Treatment would be your 100% O2. So let's look at now pathology section quickly. Let's start this. We have rhinosinusitis. Rhinosinusitis is basically we have the obstruction of the sinus drainage into the nasal cavity that will lead to inflammation and pain over the affected area. Right, and typically affects the maxillary sinuses. Maxillary are right here, and you can see this one. This one actually, the red one, which is not drained, which is full of mucus. So we drain against the gravity due to ostia located superior medially. Red arrows point to the fluid-filled right maxillary sinus. So what are we trying to say here? We're trying to say the maxilla, it is hard to drain because the meatus or the opening is superior medially, and it is against the gravity, so it is hard to drain. That's why the maxillary sinus is the one which is most commonly gets filled up with fluid and get the sinusitis. Now we're talking about superior meatus. What is superior meatus? Well, superior meatus is it drains the posterior ethmoid. Middle meatus would drain the frontal and maxillary anterior ethmoid, and all of this inferior would drain the nasolacrimal duct. Acute, now less important thing, acute sinusitis is common caused by viruses like rhinovirus, may lead to superimposed bacterial infection, commonly by non-typable H. influenza, S. pneumoniae, M. catarrhalis. Paranasal sinuses infection may extend to the orbits, cavernous sinus, and brain, causing complications like orbital cellulitis, cavernous sinus syndrome, meningitis. Right. So all they're saying is simple. Two infections here. So most common is your maxillary. Important thing. Second thing they're saying is acute sinusitis could be caused by these all viruses or could be caused by some bacterial infections, which are right there to memorize. Paranasal sinuses infections could extend, because it's paranasal, could extend into the cavernous sinus and cause complication in the brain. Epistaxis, very high yield topic. What is epistaxis? It is a nosebleed, most commonly from anterior segment of the nostril, which is called Castlebat plexus, high yield. What is coming from? Castlebat plexus. What else we have? It's a life-threatening hemorrhages occurs in the posterior segment, which is a sphenopalatine. If you look here in the picture, so what is forming this Castlebat plexus? So we have anterior ethmoid artery, posterior ethmoid artery. We have sphenopalatine artery. So anterior and then posterior. So one is ethmoid, and then you have sphenopalatine, and superior labial artery, and also greater palatine. So saphenopalatina, greater palatine, so two palatine sort of a thing, and two ethmoid, anterior and posterior ethmoid, and the last is labial artery. They all come together and form the Castlebatch plexus. What is important here? So common causes of this trauma to this area would be foreign body or either trauma, allergic rhinitis, and nasal angiofibroma, which is common in adolescent males. Castlebatch drives his lexus with his legs, and the legs is the mnemonic for all of this, which is labial artery, greater palatine artery, ethmoid arteries, and sphenopalatine artery. And yeah, that's pretty much it for that. Now we are looking at head and neck cancers. Head and neck cancer, most common is squamous cell carcinoma in all the head and all the neck cancers. Most common squamous cell. Risk factors: high yield. It is tobacco smoking, alcohol, HPV 16, which would cause oropharyngeal high yield, and EBV, which would cause nasopharyngeal high yield. So HPV 16 is going to cause oropharyngeal cancer, while EBV is going to cause nasopharyngeal cancer. Field catheterization is carcinogen, damages wide mucosal areas, leads to multiple tumors that develop independently after exposure. Nasopharyngeal carcinoma may present with unilateral nasopharyngeal carcinoma could present with unilateral nasal obstruction, discharge epistaxis, while the eustachian tube obstruction may lead to otitis media, plus minus effusion, and hearing loss. Laryngeal papillomatosis, also called recurrent respiratory papillomatosis, it is benign laryngeal tumor, commonly affecting areas of stratified squamous epithelium, such that, as a true vocal cord, especially in the children, associated with HPV 6 and 11. So here's the thing: 6 and 11 is going to cause laryngeal papillomatosis, while 16 is going to cause oropharyngeal carcinoma. 6-11, laryngeal papillomatosis, especially in children. HPV 16, oropharyngeal carcinoma, and EBV, nasopharyngeal carcinoma. And that's these three things are high yield: EBV, nasopharyngeal, EBV, nasopharyngeal, HPV, oropharyngeal, HPV 6 and 11, laryngeal papillomatosis. Let's talk about DVT, deviant thrombosis. You have in DVT, what do we have? Blood clot within a deep vein causes three things or four things: swelling, redness, warmth, pain. Okay, you in picture you can see swelling, redness, warmth, pain. Okay, yeah, that, I mean, I was gonna make a mnemonic, but it's not. I mean, I'll make it, and I might just write it on the group as a post. Okay, so root cause triad. What is root cause triad? It causes by SHE. What is SHE? SHE stasis, hypercoagulability, and endothelial damage. Three things come together, comes the root cause triad, which causes DVTs. Most pulmonary emboli arise from proximal deep veins of the lower extremity. For example, iliac, the femoral, the popliteal vein. They're saying the emboli is going to come from the proximal deep veins. This is important. What deep veins can cause DVT or can cause embolization? Iliac, femoral, popliteal veins. Now, high yield is right here, D-dimers. The test can be used clinically to rule out DVT if disease probability is low or moderate. Okay, high sensitivity but low specificity. So D-dimer is a test with a high sensitivity but low specificity. Imaging test of choice would be Doppler. So what is the best thing to do is a Doppler to check for DVT. Use how do we treat unfractionated heparin or low molecular heparin, which is enoxaparin, for prophylaxis and acute management. Use direct anticoagulant, for example, rivaroxaban, apixaban for treatment and long-term prevention. So prophylaxis or acute management, you're using unfractional low molecular heparin. Direct anticoagulant for treatment or long-term prevention. Important things. Let's talk about pulmonary emboli. What is a pulmonary emboli? It's an obstruction of the pulmonary artery or its branches by a foreign material. Pulmonary emboli, same thing, is a foreign material which blocks pulmonary artery or its branches, usually thrombus, that originates elsewhere. And we talked about from where most common areas are, or the proximal veins are the most common areas. Affected alveoli are ventilated but not perfused. So they are saying affected alveoli are ventilated but not perfused. Why? Because there's an emboli in the artery, in the pulmonary vasculature. May present with sudden onset high yield. Now this is important. How's it going to present? Sudden onset dyspnea. Out of nowhere, they started having shortness of breath. Pleuritic chest pain. Out of nowhere, you have pleuritic chest pain. Tachypnea, tachycardia. Again, tachypnea, increase in respiratory rate, tachycardia, increase in heart rate, hypoxemia, low PaO2, and respiratory alkalosis. Again, respiratory alkalosis, why did we have this? Because when you increase the respiratory rate, you're going to throw out your carbon dioxide, and that's going to cause alkalosis, respiratory alkalosis, because we're talking about respirations here. So respiratory alkalosis, it's coming from there. And large emboli, now let me change pen. Large emboli, or the saddle emboli, which is a red arrows showing a filling defect in picture A, and this is right here. It may cause sudden death due to clot preventing blood from filling left ventricle and increased right ventricular size, further compromising the left ventricle filling, which is obstructive shock. So CT pulmonary angiography, okay, let's just do it color. So CT pulmonary angiography is the imaging test of choice for PE, pulmonary embolism. Look for the filling defect. ECG, which shows sinus tachycardia, less commonly S1Q3 T3 abnormality. Line of Zehen, this is also important. What is that? They are interdigitating areas of pink platelet fibrin and red RBC found only in the thromboid form before death. So line of Zehns could be seen before death. That would help distinguish pre and postpartum thrombi, because in postpartum you will not see line of Zehen. Now in the treatment wise, what do we have? So treatment of this guy, pulmonary embolism, is anticoagulation like heparin, direct thrombin, factor XA inhibitors, IVC filter if anticoagulation is contraindicated. What are the types? The types are you have fat emboli, air emboli, thrombus emboli, bacterial emboli, amniotic fluid emboli, tumor emboli, and embolus that involves like a fat bat. That's the mnemonic. So fat, air, thrombus, anything, you name it is there. Fat, air, thrombus, bacteria, amniotic fluid, tumor. So what is the fat emboli? It is associated with fat emboli associated with long bone fractures, liposuction, classic triad of you will have hypoxemia, neurological. See, now two new things come along with the fat embolism, and that is your neurological symptoms and your petechial rash. Fat embolism is going to cause hypoxia, neurological symptoms, and petechial rash, while air emboli would cause nitrogen bubbles, which will precipitate in ascending divers, which is caisson disease or decompression sickness. Will treat with hyperbaric O2, or can be iatrogenic secondary to invasive procedure, central line placement. The last one is amniotic fluid emboli. Typically occurs during the labor or postpartum and can be due to uterine trauma, can lead to DIC, rare but high mortality. So let's just recall this topic, high yield topic, quickly. So what do we understand by this? We say it's a pulmonary embolism. Anything that would obstruct the lung from a foreign material, which would mess up the VQ, which would lead to VQ mismatch, which would, once you have VQ mismatch, you will go into shortness of breath, pleuritic chest pain, tachypnea, tachycardia, hypoxemia, respiratory alkalosis. But if that obstruction is large enough, you might lead to death. And how large are we talking about? With saddle emboli. If you look here, way too big. Embolism, right? So that can lead to sudden death. But how do we check this out? What are the tests we can run? We can run a CT, pulmonary angiography. We can do ECG that can check up the things there. And line of Zen can be seen if the emboli is before death. How do we treat it now? Well, the treatment is simple: anticoagulation, IVC filter. What are the types of these pulmonary emboli? It could be fat bat. It could be fat. Where do we get the fat emboli from? Liposuction, anything with the bone fracture, liposuction, where the fat goes into the blood, right? And now when the fat goes there, there's some special triad, and that triad is called hypoxia, neurological, and petechial rash. Rash, you look at, hey, rash, you're getting a rash after a liposuction? After a bone fracture, you're getting a rash? Makes sense. Neurological symptom, rash, and hypoxemia. Air embolism. Where do you get air embolism from? Well, if you are going into your divers who have caisson disease, decompression sickness, they're going to get air embolism, which you will see nitrogen bubbles precipitating in these caisson disease decompression sickness. And also, if you place a central line placement, this is a very common procedure. There's a risk of getting an air embolism in those patients. How do you get amniotic fluid emboli? So at the time of delivery, at the time of labor, postpartum, due to uterine trauma, you're going to get that amniotic fluid embolism. It can even lead to DIC. It is rare but high in mortality. And that's all for the pulmonary emboli. Looking at the next topic, which is mediastinal pathology, and this is going to be the last topic before we take the break. Okay, so mediastinal pathology. So normal mediastinum contains the heart, the thymus, the lymph nodes, the esophagus, aorta. What normal? Heart, thymus, lymph nodes, esophagus, aorta. And these structures, if there's any problem with them, they're going to cause mediastinal pathology. Let's talk about the masses now. The mediastinal masses, some pathologies like lymphoma, lung cancer. Lung was there, so lung can cause lung cancer. Abscess can be there. Lymphoma can be there. Can occur in any compartment, but there are common associations. Anteriorly, the masses anteriorly are 4 T's, which are thyroid, thymus, teratoma, which is and terrible lymphoma. I mean, it's just a lymphoma, but to mention it T, it's called a terrible lymphoma. The other one is middle. In the middle of the mediastinum, you can get a metastasis, hiatal hernia, bronchogenic cyst. In the posterior of the mediastinal mass, you can have esophageal cancers, may present a mass or spread to middle mediastinum, neurological tumors like neurofibromas, multiple myeloma. So posteriorly, just think about you just think about neuronal structures. Middle one, you think about the metastasis or some lung associated. In anterior, you just have 4 T's: thyroid, thymus, teratoma, terrible lymphoma. Medianitis, now inflammation of the mediastinal tissue, commonly due to post-operative complication of cardiothoracic procedures less than 14 days. So in a cardiothoracic procedure, a patient is less than 14 days after the procedure, and they develop medianitis, which is the inflammation of the mediastinal tissues, which can also, one of the complications is esophageal perforation or contagious spread of the odontogenic retropharyngeal infections. Chronic, and this is acute, by the way, less than 14 days. Now, chronic medianitis, also called fibrosing medianitis, due to increased proliferation of connective tissue in the mediastinum, caused by histoplasma capsulatum is a common cause. Clinical feature of medianitis is going to be fever, for sure. Medianitis, fever, tachycardia, leukocytosis, chest pain, sternal wound. What is the important or sort of a clue in here? Sternal wound drainage. There is a sternal wound drainage after cardiothoracic procedure. You think about medianitis with all the fever and everything for sure. So now pneumo means air. Air in the mediastinum is the presence of gas. Usually the air in the mediastinum can either be spontaneous due to rupture of the pulmonary bleb or secondary to trauma iatrogenic Boerhaave syndrome. Rupture alveoli allow the tracking of air into the mediastinum via peribronchial and perivesicular sheaths. Okay, and air tracking will be seen. Clinical features are important. What are they? Chest pain, dyspnea, voice change, subcutaneous emphysema, plus Hamman sign, which is crepitus on the cardiac auscultation. Why do we have crepitus? Because that air we talked about that has been tracked up into the peribronchial and perivesicular sheath, which will cause crepitus on the cardiac auscultation because it's air. And this is again, important feature of this disease. Crepitus on cardiac auscultation, you think about pneumo mediastinum. Sternal wound drainage, you think about mediastinitis, mediastinal, right? Medianitis. Masses, you think about either anterior, it is middle part, or is it posterior? Anterior is T's, middle is all about the lung problem, and posterior is all about neurologic problem. And that's all for this topic.